Alright, hi everyone, I am Dr. Sourabh and today I am going to tell about in the Medskool session of approximately 1 hour about retinal angiography and optical coherence tomography. So the purpose of this, it will cater to the third years. For the third years, there should be a basic knowledge of what is the meaning of this word angiography, and for those who are preparing for Neet PG exam, foreign medical graduate exam, they should know some important clinical aspects as well. So I'll start with the very basics because these two investigations are very important for third year as well as PG exam. So meaning of angiography means angio means blood vessel and graphy means study. So study of the blood supply of the retina and choroid, that is retinal angiography. And optical coherence tomography investigation. Tomography means, topography means surface and tomography means sections. So it's a very important investigations for the sections of the retina, mainly central retina. So vascular and the structural two tests we are going to discuss now, and along with that I'll tell you about the clinical applications as well. Okay. All right, just give me a minute. So it's a very important investigation for the section. All right. Hi Monisha. Hi. Hi Subhash, Revati, Neha. So I'm going to. We can't jump onto any investigations before if you don't know the knowledge of the basic structure of the retina or some basic layers of the retina or the blood supply of the retina. This is the basic to understand these two investigations. So let us now, this is the eyeball, this is the iris, this is the pupil. Let us dilate the pupil and let us go inside the eye. Let us go inside the eye and then let us see the retina, how the normal retina looks like, what are the parts of a normal retina, what are the layers of the normal retina, what is the blood supply of the normal retina. Let us see. So this is the optic disc, okay, and which vessels are coming from the center of the optic disc? Central retinal vessels. Artery comes inside, vein goes outside. And this is entire retina. So this is the optic disc and this is the central part of the retina, which is known as a macula. This is the normal retina. These are the artery and the veins of the retina. So if I ask you that this is which retina, the right or the left, how we are going to say this one or this one? This is the optic disc and this is the central part of the retina. So if we say that which retina is this, it has to be taken as a observer's view. Observer's view means this is the patient who is standing face to face, like you are seeing in mobile phone or computer screen. Your computer screen is your patient, mobile phone is your patient, and you are standing face to face. So this is the patient's retina. For example, I am your patient, I am standing face to face towards you. This is my right eye, this is my left eye. So this is the optic disc. Optic disc is in the nasal side of the retina. And if we go temporal, this is the temporal side of the retina. This is a small point known as fovea in the temporal part of the retina. Surrounding fovea, there is an imaginary space known as fovea. And surrounding that, the word I took just now, imaginary space known as a central retina known as macula. And then we have the peripheral retina till ora serrata. So this fovea, macular, imaginary spaces on the temporal part of the retina. So this will be the superior retina, of course, this will be the inferior retina. And I have told you this is observer's view. So which retina is this? The fovea is always on the temporal side of the retina. So if I am standing face to face, my right eye fovea is on the right side. Temporal of the right is right side. My left side fovea is on the left side. If you are standing face to face. So this is a patient who is standing face to face. Here the fovea is on the right side of the optic disc. So this has to be the right retina. Good. If I draw a picture like this, this is left retina. This is for the laterality of the retina. Now let us see which vessels are coming from the center of the optic disc. I'll tell you the blood supply in detail, but see these vessels are coming. These are central retinal artery and veins. Now which one is a vein, which one is an artery is very important to know. How to identify? by the ratio of the artery to vein. So this is 1 and this is 2. 1 is a artery, 1 is a vein. We have to know which one is the artery, which one is the vein, if you know the arteriovenous ratio. And in normal retina it is 2:3. Means the artery lumen is narrow than the lumen of the vein. So I hope you can tell now which one is the artery, which one is the vein. One is what? A branch of central retinal vein, and this 2 is a branch of central retinal artery. 2:3. The lumen is the ratio. So artery lumen is narrow. So this is the one which I mentioned. 1 is a vein, this is artery. Okay, good answers everyone. This is a basic. I am starting with the very basics, because we know the basic structure of the retina, the parts of the retina, the vascular supply of the retina, then only we can jump on the investigations. To know the investigations, you have to know the basic structure, layers of the retina. Let us see the layers of the retina, because that is also very important to understand. So if you know the 10 layers of the retina, I hope you know. Retina is your screen for today. Your screen, mobile phone is your screen. In front of retina is the vitreous, behind the retina is choroid, and behind that is a sclera. So if we go from vitreous to retina to choroid, what are the layers of the retina? Let us quickly revise this before going on to the structural. Whenever the word inner comes to you, the inner word is towards the vitreous. So inner limiting membrane is the first layer of the retina, not very important. Then we have a nerve fiber layer. This nerve fiber layer is actually the axons of some cells. These cells are ganglionic cells, and this nerve fiber layer will ultimately form the optic nerve, which goes outside the eye from optic disc. So ganglionic cell is a cell body whose axons are nerve fiber layer, and this ganglionic layer receives the impulse, if you know somewhere about the visual pathway, from these cells. These cells are located in inner nuclear layer, in which this is the bipolar cell. 3 more cells are there, amacrine cells are there, Muller cells, horizontal cells. In the visual pathway, if you know, the bipolar cells send impulse to ganglion cells, which are axons, nerve fiber, which forms the optic nerve. Then it goes outside the eye, chiasma, tract, LGB, visual cortex, visual pathway. So from one cell body, the impulse goes to another cell body by synapse. So the word plexiform in retina is synapse. So inner synapse is a synapse between the bipolar cells or the inner nuclear and ganglionic layer. Whereas the inner nuclear is receiving the impulse from these cells. What are these? These are outer nuclear layer. They are the rods and cones photoreceptors nucleus. And from here the impulse goes into bipolar inner nuclear via outer plexiform layer, which is also known as Henle's layer, identified by a scientist, Henle's layer. Now if we have an inner limiting membrane, right, if someone has coined the term inner limiting, inner is towards the vitreous, outer is towards the choroid. There has to be the outer limiting membrane also, not very important. So what is outer limiting? It is a junction between the outer nuclear, which is the rods and cones nucleus, and the main segments of the rods and cones. The inner segment, outer segment of the rods and cones are the main rods and cones layer. These 9 layers of the retina, these are 9, 1, 2, 3, 4, 5, 6, 7, 8, 9. There are 10 layers of the retina. But this 9 layers is actual the main retina tissue, transparent tissue, neural tissue, known as neurosensory retina. This is transparent tissue. But the retina looks like reddish orange. Why? Because of choroid behind the retina, which reflects the light. The 10th has some pigments. This 10th layer has some pigments known as retinal pigment epithelium. And it has a pigment known as the melanin pigment. And melanin pigment is maximum at the central retina fovea. By fovea, I mean included foveola as well. So these are the 10 layers of the retina. We can divide the retina into 2 layers. Inner 9 neurosensory, and the 10th is retinal pigment epithelium. After that comes choroid. Who knows the first layer of choroid? I'll just mention over here because this word will come in some time. Brooks membrane is the first layer of choroid. Then we have choroid vessels. Then we have suprachoroid space. Then we have sclera. So this is screen is your retina. In front there is vitreous. Then 10 layers of the retina. Brooks membrane, choroid vessels, suprachoroidal space, and sclera. Now what important point is, the central part of the retina, I told you fovea does not have all the layers. All the 10 layers are not there. Now fovea contains only cones. Only the cones are there. And if cones are there, the nucleus of cones has to be there. And in between them there is the outer limiting has to be there. So fovea contains, see, inner limiting, outer limiting, retinal pigment epithelium are present everywhere. Only cones are present, not rods. And if cones are present, and nucleus is also present. So if you want to count, you can count only 5 layers are present in fovea. And what is the imaginary space outside the fovea? You think, who will send the impulse from the cones to bipolar cells? Because if you have to see for cones of color, which if you have to see the cones, the impulse has to go into bipolar cells, then ganglion cells. But bipolar cells are not present in the fovea. They are present everywhere in the retina, but not at fovea and fovea. In fovea, there is a outer, one layer is extra. Outer plexiform layer is extra in fovea, means 6 layers. Because outer plexiform is a synapse. It is a synapse between the cones and the bipolar cells. The rest of the retina macula contains all the 10 layers. All the retina contains 10 layers. So this outer plexiform I told you is Henle's layer, was identified by Henle scientist, and this outer plexiform has a radial configuration in the central retina. Let us imagine why. Because it has to take the impulse from the cones to bipolar. Cones are there in fovea and fovea, but bipolar is not present in the fovea and fovea. So it has to go radial configuration in the central retina, because it has to reach the bipolar, which is at the macula. So who will take the impulse? Outer plexiform, synapse, discovered by Henle scientists, and there is a radial configuration of Henle's. This will come as a clinical point later on. And that is why the central retina does not have all the 10 layers. If you do a scanning of the central retina, this investigation is known as optical coherence tomography, OCT. It is in the same orientation in which you have seen the layers. What is the orientation? We can draw also. This red line is the retinal pigment epithelium. This is the neurosensory retina, the 9 layers of the retina. Here there is vitreous, retina, choroid, sclera. Why there is a curvature in the central retina like this? The reason is in front of you. The fovea has 5 layers, fovea 6, and the rest of the retina has 10 layers. That's when the normal curvature of the retina in the center is like this. This is a normal optical coherence tomography. Good, Vinayak. So this is our investigation, a scanning. Please remember, OCT is only for central retina, not for the entire retina. It is a specific investigation for central retina, which is macula. This is the normal OCT. Again, I'll zoom and show you, because clinical implication will come later on. See very carefully. This red line is a retinal pigment epithelium. This is a neurosensory retina. There is a curvature like this. This black is the vitreous, retina, choroid, sclera. Fovea has less layers. That's why there is a curvature in the normal retina like this. All right. Now let us go to the vascular supply. We have to know the vascular supply of the retina and choroid before I tell you the angiography. So the main artery which is supplying the blood vessels in the eye is internal carotid artery, whose branch is ophthalmic artery. And I hope you know ophthalmic artery enters the orbit. Orbit is like this. I can't tell everything in detail, but from the optic canal, optic nerve goes outside, ophthalmic artery comes inside from the apex of the orbit, optic canal. And all the branches inside the eye are branches of ophthalmic artery. The major ones are, of course, the name central retinal artery, Choroidal vessels. Now choroidal vessels can be anterior ciliary, posterior ciliary. Let us see, just see the video. I'll tell you. There can be short posterior ciliary arteries, long posterior ciliary arteries. Short posterior are 15 to 20. They are supplying around the optic disc. All these are branches of ophthalmic artery. See these two green. These are two, only two long, because they are going from posterior to anterior in the suprachoroidal space. There are two long posterior ciliary arteries which are coming from posterior to anterior. 15 to 20 short, only two long. And this long comes anteriorly and anastomose with the 7 anterior ciliary artery to form the arterial circle of the eye around the iris and the pupil. So till now I have just told you the ciliary arteries. Again I will just revise. It can be anterior ciliary, can be posterior ciliary. Posterior ciliary can be short, can be long. 15 to 20 short, surrounding the optic disc they supply, forming an anastomosis, Zinn-Haller anastomosis. Two long posterior ciliary comes from behind, comes anteriorly to anastomose with the anterior ciliary artery. I hope you know why there are 7 anterior ciliary arteries. Two for each rectus muscles, except lateral rectus. There are 4 rectus. So 2 into 4 should be 8, but lateral rectus gets only 1 anterior ciliary arteries. That's why anterior ciliary is also known as muscular arteries. So 2 for each rectus except lateral rectus. Anterior ciliary anastomose with long posterior ciliary to form the arterial circle of the eye, major, minor. Now comes the major one, the central retinal artery. See, it is a direct branch of all our branches of ophthalmic artery, but it enters the optic nerve. Central retinal artery enters the optic nerve and supplies the inner 6 layers of the retina, which I'll tell you in detail. But to supply the inner 6 layers of the retina, it has to enter the optic disc. From the center of the optic disc, the vessels which are seen are central retinal artery and vein comes outside. How to tell? 2:3. The lumen of the artery is less. Means whatever vessels we see in the retina are all the branches of central retinal artery and vein. Choroid is behind. Choroidal vessels is not seen in the retina. This picture, who can tell me this is which retina, right or left? Answer is left. Now who can tell me which one is the artery? Which vessels are these? All these are central vessels. This one is a central retinal artery branch. This one is a central retinal vein branch. Behind this is choroid, which is not seen. Acha, in which condition choroidal vessels are visible? Can you think logically? In which the retina is thick or thin? Of course, when the retina is thin, choroidal vessels become prominent. Normal choroidal vessels become prominent. And retina is thin in long eyeball or small eyeball? Long eyeball. So high myopias, choroidal vessels will be visible. Like seen in pathological myopia are known as tigroid, tiger-like fundus, because the choroidal vessels will be visible in there. But now we are talking about normal patients. So this is the left retina. All these vessels which you see in the retina are central retinal vessels and arteries. Okay. All these vessels, arteries will now become vein also, and then they go out. Like central retinal vein also comes outside the optic disc. Venous supply I am not touching over here. But there are of course veins as well. Now based on this, very good answers. Based on this, see this is what I told you. ICA, internal carotid artery, branch of ophthalmic artery, enters the orbit. Only one central retinal artery. How many anterior? Known as muscular, 7. 2 long, 15 to 20 short posterior ciliary arteries. And these two anastomose to form arterial circle of the eye, major and minor arterial circle. This is the blood supply, ICA, ophthalmic artery and so on, which I just showed you in the video and explained. Based on this, let us go in detail. The branches which you see in the retina, central retinal artery, histologically there are 10 layers, but central retinal artery supplies only the inner 6 layers of the retina. Means there is a watershed zone between the inner 6 and the outer 4, because outer 4 does not have any blood supply. Yes, they get nutrition from the choroid, but there is no direct blood supply of the outer 4. And central retinal artery is normally present in histologically in two levels, superficial level and deep level. Superficial is at the level of axons, that is nerve fiber layer, and deep is at the level of outer plexiform inner nuclear. For MCQ purpose, you can take it as outer plexiform, and superficial is at the level of nerve fiber. Central retinal vessels are intraretinal or extraretinal. Think and answer. Are they inside the retinal tissue, outside? Of course, they are inside. Ciliary vessels are outside, they are extraretinal. Now, the vessel, whether inside the retina or outside the retina, vessels contain blood and fluid. The blood and fluid should not enter the retina. So, very, very important, there is a inner blood retinal barrier for the inner 6 layers of the retina, formed by the retinal vessels endothelium, which will not allow the blood from inside the vessel to come out. And the choroidal vessel should not come, the choroidal fluid should not come into the retina tissue. So there is an outer blood retinal barrier formed by tight junctions of RP and the first layer of choroid Brooks. This is the vascular supply of the retina. Knowing this is very important to understand angiography. Again, I am repeating. Central vessels are intraretinal, majorly at two levels, superficial and deep. The fluid from central vessel should not come to the retina. Who prevents? Inner blood retinal barrier, applicable for inner 6 layers. While choroidal fluid and blood should not come to the retina. Who prevents? The outer blood retinal barrier, formed by retinal pigment epithelium and Brooks membrane. Now, let us apply this knowledge of the vascular supply and the structure in angiography investigation, study of the blood vessels and of choroid and retina. Let us see very carefully. At least you can tell me which, this is angiography, at least you can tell me this is right or left retina. I am showing right angiography. This is optic disc and this is the fovea central retina. All these vessels you see are central vessels. Choroidal vessels are behind, it's not seen. Retina is your mobile screen today, okay? So let us start from the basics. In angiography, let us start the basics of science. Basics of science was which, why, how. One thing is, a dye is used in angiography. First question, which dyes? Answer is, fluorescein dye can be used, indocyanine green dye can be used. This is which, fact. Why? Why only these two dyes can be used? Because these two dyes have a property of fluorescence. Very, very important property of fluorescence is, I will call this cup of tea or whatever as a fluorescence property. If an incoming light coming to this cup is low wavelength, it has a capacity of emitting higher wavelength, that is a fluorescence capability. What is coming? Low wavelength is coming inside. Wavelength, not frequency, in the object, and it has a capacity of emitting higher wavelength, that is a fluorescence capability, is present in fluorescein dye, indocyanine. And for MCQ purpose, very important, which, you know, Vibgyor, visible light. This is visible or non-visible? You see Vibgyor, na? Violet indigo. Increasing wavelength. So in fluorescein, blue light is coming inside and green goes outside. See, blue has a lower wavelength, Vibgyor. Blue light comes inside, green goes outside. That is satisfying fluorescence. ICG works in infrared, after red. 400 to 700 nanometers, physics, we are good in physics also, maths also, everything. After that is infrared. So ICG not very important, but just 810 nanometers comes inside, 840 goes outside. That is also satisfying fluorescence capability. So we answered two questions in angiography: which dyes are used, why these two dyes are used, how these two dyes are used. How will you make the dye reach the retina vessel or choroidal vessels? It has to reach the retina vessels. That's why you see all these white as dye. Where will you give injection? I just told you the blood supply. You will give injection in ICA, ophthalmic artery, central retinal artery, choroidal ciliary artery, or ICA comes from common carotid, arch of aorta, heart. You will give injection in heart. हार्ट में तो काम ही खत्म कर दो, पेशेंट खत्म, काम खत्म. है ना? So you give injection where? Very important. You give injection in the antecubital vein in the forearm. Track this, very very important. If you give injection in the antecubital vein in the forearm, track this. It will come into heart. From heart it will go into ICA, common carotid, ICA, then ophthalmic artery, then central retinal artery, then ciliary. All these are the track of the dye to reach the eye. Dye in eye. And there is a machine. Patient is sitting on this. And I'll show you a video. It's a photographic, it's a continuous process angiography. Various phases are there in angiography. To make you understand better, I'll show you. So that is an important thing. You are putting a dye in arm and you are expecting the dye to reach in retina in 11 to 12 seconds. Arm retina time is 11 to 12 seconds. It will reach artery first or vein first. In retina it will reach artery or vein first. First of course artery, now from heart it will go into artery, then it will go to vein and then go outside. I'll tell you the phases. Of course the dye goes into ciliary vessels as well, choroid. 1 second earlier. Ciliary vessels are anatomically filled 1 second earlier. But nobody is going to ask you arm choroid time. They ask you arm retina time. Okay, this is the which dyes, why these two dyes, how the dye is used. Now factual. Good, Shravan. 11 to 12 seconds is okay. Now a factual thing. Angiography. There are two types, na? Fluorescein and indocyanine green. Okay, based on which dye is used. Mostly we in the exams fluorescein angiography is asked. ICG is in infrared spectrum. This is in visible spectrum, I told you. Now, why ICG is better for choroidal circulation? Because it is more bound to plasma proteins. It cannot cross the barrier. So if you want to know the choroidal pathologies, this ICG is better. A question came now, I'll tell you. Occult choroidal pathologies. Occult, you know, chupi hui, hidden. For hidden choroidal pathologies, which one is better? ICG angiography. Because it will not cross the blood retinal barrier. Choroidal vessels are more prominent in ICG angiography. Pictures of ICG angiography is not asked at third year, of course it is not asked. You just have to know the theory in third year. For PG exam also it is not asked. Fluorescein can be done for retinal and choroidal circulation both. So these are some facts between the fluorescein and ICG angiography. Let us now concentrate on fluorescein angiography. As I tell you, it is a continuous process. So see very carefully. Right, angiography. There are two areas, black and white. White are the areas where dye is present. White is the area where the dye is present. If the dye is present, it is known as hyperfluorescent. And where the dye is not present, that is hypofluorescent. Now you see carefully. I'll show you a video to better explain. I told you to put the dye in antecubital vein, it goes into heart, it goes into choroidal vessels first. So that is why if you see it's a continuous process, there is a choroidal phase. The choroid is filled, right? Angiographic choroid is filled first. Then artery is filled first. This is artery, not vein, you will realize. Then arteriovenous phase. It will go into vein. Then the main vein phase. See, 2:3 ratio, vein is bigger in lumen. And then it will go outside the eye, that's the late recirculation phase. You see here, this is the right, this is the, if you see carefully, this is the artery, this is the vein, 2:3. I'll repeat the video, you'll better understand now. See, first phase, it goes into choroid, then artery, arterial phase, then startly our vein is filling, arteriovenous phase, continuous process. Then the vein is fully filled. How to differentiate? 2:3. Vein is bigger lumen. And then it will not remain in the eye, it will go outside the eye. It's the recirculation phase, that's the late phase. Usually these phases are not asked in PG exam, but this is just to know that it's a continuous process. Angiography is a continuous, there is multiple photographs taken at different stages. So, the vessels are having dye. Means retina vessels, choroidal vessels are hyperfluorescence or hypofluorescence. retina vessels, choroidal vessels are hyperfluorescence. Retina, choroidal vessels are hyperfluorescence. But now the question is, why is the dye not coming out of the retina vessel? Why it is not leaking? Because of the inner blood retinal barrier. And if you see, retina is a screen, behind the screen there is whitish choroidal vessels. Why is the dye not coming in front? Because of outer blood retinal barrier. That's why the dye remains in the retina vessels, choroidal vessels, because of inner and outer blood retinal barrier. And this area, fovea, foveola, is hypofluorescence. And someone has mentioned very carefully, very good, Vinayak Divya Vinayak, because why it is fovea is dark? Because it is a avascular zone. Fovea has 5-6 layers. It does not have CRA circulation. It is known as the fovea avascular zone. If you zoom it, you see the vessels are not reaching the fovea foveola of the central retinal. Only at the periphery it is there, because it does not have the only 5-6 layers are there. So how is fovea getting nutrition? It is getting nutrition from choroid. So why are we not seeing the dye of the choroid at the fovea? I gave you the answer today only. Because some pigment is very high at the fovea. Melanin pigment at the RP is very high, that it is masking, blocking the dye of the choroid. So because of high melanin pigmentation, and one more, there is xanthophyll. These two pigments are so high at the fovea that the choroidal dye is blocked. The block we word use, masked. It is masking the circulation of the choroid. That's why normal angiography, fovea is dark, retina vessels, choroidal vessels are hyperfluorescence. Good, Shravan. So can someone answer this question for me? This is right angiography. Retina vessels, choroidal vessels are hyperfluorescence, fovea is hypofluorescence. And in angiography, there is a continuous process. I showed you the video. The dye is present. At some stages, dye should be present in choroid, retina vessels, choroidal vessels. Dye should be present because you are using the dye. But can someone tell me which investigation is the next picture which is coming? This is angiography, yes, right angiography, fluorescein angiography. But which is this investigation? This is right retina. Now this is not angiography. Because you see, this is a still picture, yes, not a video, but you see the vessels are not having a dye at all. This is autofluorescence. Retina itself has the property of autofluorescence. You throw any light, it will emit higher wavelength light. So in your exam, autofluorescence will come less. But you should know how to differentiate auto from angiography. How will you tell? Just look at the retina vessels. A little bit dye also. Sometimes there can be late stages. Dye must be present. Autofluorescence, dye is not used. If dye is not used, the retina vessels, choroidal vessels are absolutely black. That is the difference at your level for autofluorescence and angiography. Now third year people, everyone including the third year should know till this point, every one of you should know this. Let us apply the knowledge. But for applying the knowledge of these investigations, you should know a little bit about the retina pathologies. So if third year people have read that, that is okay. But those who are appearing for PG, they should know some points. I'll revise also. Let us apply the knowledge of OCT and angiography in how the questions are framed. Now this I am just giving. Just see. That can be cause of hyperfluorescence, means more dye is coming. You see more dye in the angiography. I'll tell you the meaning of pooling, leaking, staining, window defect. And hypofluorescence can be something is blocking the dye, or hypoperfusion. No dye is not coming into the retina. Each word I will mention as we go on to clinical applications. Don't worry about that. Good answer, Divya Anurag. One example of each I am going to tell you, and then I'll ask you questions also later on. Let us see the first one. Who can tell me which investigation is this? OCT, angiography. Answer should be, sir, optical coherence tomography. Normal, abnormal? Answer should be, sir, this is normal. If there is a outer barrier break, so outer barrier break is made up of RP and Brooks membrane. So if there's a break, what happens? The choroidal fluid can come between the 9 layers and the 10th layer, causing what? This is OCT causing what? Normal, abnormal? So this is abnormal. What is happening here? If you know some pathology, the neurosensory retina is separated from the retinal pigment epithelium because more choroid fluid is coming due to break in the outer barrier in mostly a young patient, a young male, central vision loss, distorted vision, metamorphosia, under stress, maybe intern, maybe married. I mean, not all married are like that. So young male, central vision loss, metamorphosia, more fluid is coming from choroid. This is a type of retina detachment, exudative retina detachment, because more fluid is coming from choroid. This is a central retinal exudative detachment. What is the answer? Anyone? Very good. Answer is central serous retinopathy. It is a central serous retinopathy. There is a central retina is detached. The definition of retinal detachment is the 9 layers are separated from 10th. You can tell in OCT that 9 layers are separate from 10th. Structure you can tell. But how will you know the barrier is broken down? That you cannot tell on OCT. That you have to tell on this investigation. See, who can tell me this is right or left? Right, angio or auto, please. See the vessels die. Right angiography, normal, abnormal? Abnormal. Because in the center there should be dark. Now there is a hyperfluorescence. Why? Because if you put a dye, it will go into heart, choroid. The dye is pooling into this space is known as subretinal space, and the dye is rising like a smoke is rising. Who can tell me the appearance? Smokestack, ink blot appearance. So this is the appearance of pooling of the dye, which is the cause of hyperfluorescence. Structure is seen on OCT. Break of the outer barrier is observed on angiography. CSR is an example of pooling of the dye. Pooling means it is pooling into some space. That is hyperfluorescence. First example, clinical application. Good. Yeah, you can call it inverted mushroom, you can call it mushroom or inverted, someone calling umbrella. But classically it is known as ink blot smokestack pattern. Treatment of CSR, who can tell me? 3 months, nothing to be done. Okay, after 3 months, you close the outer barrier by photodynamic therapy. So that's the first example of clinical application. Pooling is an example of hyperfluorescence. Everyone okay with me? Good answers. Leaking. Let us see example of leaking. The dye is leaking from the vessel. So see this. If there is an inner barrier break, inner barrier is applicable for inner 6 layers. Central vessels will leak. So inner barrier can be broken down in diabetic retinopathy, central retinal vein occlusion, branch retinal vein occlusion due to a chemical mediator, vascular endothelium growth factor. Inflammation can break all the barriers in the retina and the eye. So inflammation like uvea inflammation, uveitis. After cataract surgery, there is an inflammation known as Irwin gas syndrome. And many drugs can break the inner barrier like prostaglandins, high doses of niacin, adrenaline. All these can lead to inner barrier break. So if there is an inner barrier break, central vessels will leak, the fluid will come out. Now if this is just for example, okay, for example, if this is a central vessels and the fluid is coming out, 2 levels I told you, nerve fiber layer, outer plexiform layer, which has more extravascular space, axons or synapse. Synapse has more extravascular space, so the fluid tend to go into outer plexiform layer, told by Henle's layer, radial configuration, because it has more extravascular space. Synapse has more space, and most dependent part of the retina is macula. It most goes into the macula, that is the central retina, forming a cystic spaces in the central retina. Who can tell me the diagnosis? Structural diagnosis. OCT, red line is RP, Is there a central retina detachment? Answer should be no. The thickness of the central retina is increasing, forming a cystic spaces because of fluid, mostly in the outer plexiform layer. This is the edema of the central retina. Cystoid macular edema is an example of inner blood retinal barrier break. But this picture just shows macular edema, nothing else. Cystic in the macular edema. It is not showing inner barrier break. Inner barrier, again, because of, how will you tell? Because of the vascular investigation. Who can tell me now? Right or left? Left. And please be careful, because 90% people will say wrong. I've showed you video today. 90% people will wrong that it says auto or angiography. Please, careful. Please look at the vessels, entire vessel, and tell me this is auto or angiography. If you're saying auto just by looking at this, that is wrong. Because see, there is a dye, it is a late stage, the venous stage, circulation phase. What is happening? The dye is also leaking. The dye is leaking from the central vessels. The dye also come into outer plexiform, and the dye is leaking, example of leaking, and the outer plexiform has a radial configuration. So this is known as a flower petal radial configuration, because of which layer? Outer plexiform. How everyone has answered. Angiography, very good, except Sharma Rateria, that is wrong. Prerna Nishi, wrong. You see, this is the angiography. Some dye is still present. There is a late stage of angiography. Dye is leaving, and if the dye is leaving, it goes into leak into the outer plexiform space. Mostly, the question is asked: this flower petal is because of which layer? Answer is outer plexiform layer. Who told? Henle's layer. A radial configuration. This is a flower petal configuration. Example of leaking of the hyperfluorescence. Second example of hyperfluorescence. Treatment I can't. For diabetic retinopathy, venous occlusion, intravitreal anti-VEGF injections. For inflammation, steroids. Stop the drugs if the drug is the example. So after pooling, second example is leaking. Now let us go one more step further. If you know the clinical pathology, at least you can tell me this is right or left. Right retina. Some yellow deposits are there in the central retina. Only the center. So I'll give you a hint. This is an old patient. Old patient comes to you with central vision loss, with distortion, metamorphosia. Old patient, central vision loss, metamorphosia. And I'll give you a hint. These yellow deposits are known as drusen's. Who can tell me the diagnosis of this question? Old patient, I give you a hint. Macula degeneration. Age related macular degeneration. And this drusen's are deposited in the RP layer, Brooks membrane. For MCQ purpose, you can go with Brooks membrane. And see this, drusen's are in the late stages of angiography are taking up the dye. This is right angiography. Drusen's are taking, staining means they are staining with the dye. They take up the dye in the late stages of angiography. This is the third example of staining of the drusen's in age-related macular degeneration. Very good answers. Iris, Gouda, Akash, Sharma, Criteria. Very good. But drusen's also have a property. Now let us see, Sharma, if you can answer this question. Tell me, this is auto or angio now? This is angiography, yes. This is autofluorescence. Drusen's have a property of autofluorescence. If you throw any light, they will emit the higher wavelengths. So this is autofluorescence. In drusen's also, autofluorescence is valid. But this is these two are, as I go, I am going with the higher steps. You diagnose age-related macular degeneration by the word drusen's. This is an example of staining of hyperfluorescence. That is important. And one extra point I told you, drusen's have a property of autofluorescence. In autofluorescence, they will give you some white. I'll tell you later on why there is black. Later on you will understand why. But third example of hyperfluorescence, staining. Good, sweetie, Bhavna. But if you know the pathology of drusen's, AMD, I told you, Photoreceptors, RP, Brooks membrane, choroidal vessels. Normal. Drusen's are deposited in RP and Brooks membrane. And if the choroidal vessels now break the outer barrier, now the choroidal vessels can also grow. Now this is a type when the choroidal, CNV means choroidal new vessels grow, that is known as wet ARMD. When only Drusen's are there, it is known as dry ARMD. And can someone tell me in an animation, this is the central retinal detachment, yes or no? Today also I answered, in this small session I answered this question. All the 10 layers are separated from choroid. This is not central retinal detachment. This is a sign known as pigment epithelium detachment. When the 9 layers are separated from choroid, that is known as retinal detachment. This is PED, pigment epithelium detachment. So very advanced point. Choroidal new vessels are coming. Okay. So new vessels are abnormal vessels. Choroidal new vessels are, any new vessel is abnormal, they can also leak the dye. So if you see, this is angiography, left angiography, this is a very difficult question, not asked in PG exam. Why I am giving, you will understand why. So this is left angiography. What is this white? Hyperfluorescence. This is choroidal vessels which is abnormal, which is leaking the dye. So another example of leaking is new vessels. Here in ARMD, choroidal new vessels are leaking, and I'll tell you why this is black later on. You have to answer this question, why this is black. I'll tell you it one example later on. So one example of leaking is also new vessels. Fourth is a window defect. Now, window defect, this picture can be asked, yes, definitely, just for spot diagnosis. What is the diagnosis? OCT, and there is a hole in the center. This is a macular hole. This is a macular hole. So if there is a macular hole, if you do angiography, what will happen? Retina is not there. Directly you will see more choroidal vessels in the center. Means that here the fovea is not dark. If you do a angiography, see, it is still angiography because some dye is still present. In macular hole only OCT picture can be asked. But you see over here in the center, there is a small white window defect because there is no retina. So choroidal vessels will also be seen over here. That is an example of hyperfluorescence. Not very important. This is very important. This for spot diagnosis. But yes, window defect is an example of hyperfluorescence on angiography. If you answer macular hole, that is more than enough. So till now we have discussed what? We have discussed these 4. Can you tell me example of pooling? CSR, leakage, abnormal vessels, new vessels, or cystoid macular edema, staining, Drusen's, ARMD, window defect, macular hole. Now let us see examples in which there is dark, more than dark in the retina. Let us see. Very important. I am giving a hint. This is a diabetic mellitus patient, uncontrolled diabetes mellitus patient. Angiography, autofluorescence. Right angiography because you see the dye. Dot, 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 dot. In diabetic mellitus, there is a capillary, is a microvessel disease. There is a surrounding the capillary, there are cells known as pericytes. In diabetic retinopathy, pericytes are lost. Extravascular space increase. So small vessels can proliferate. Small vessels proliferate is known as microaneurysms. If you do angiography, the dye will also come into like dot 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 dot. All these small dot 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 are, I'll give you a picture another only for microaneurysms. That is a hyperfluorescence example of hyperfluorescence. Here will be what of these 4? Leaking, staining, what? Microaneurysm will also be example of leaking. Microaneurysms are also example of leaking hyperfluorescence. But in advanced stage of diabetic retinopathy, you see this yellow arrow. Yellow arrow is dark or white. Now this is hypofluorescence. In diabetic retinopathy, in advanced stages, retina blood supply decreases. Means this is retina ischemic retina, hypoxic retina. So hypoxic retina become example of a filling defect. Ischemic retina, hypoxic retina. As the name suggests, there is no blood supply. Yellow area is hypofluorescence. And hypoxic retina has a property of producing VEGF. And VEGF causes retina new vessels. And I just told you retina new vessels are also abnormal. They are hyperfluorescence on angiography. See, all these white are hyperfluorescence, black arrows are hyperfluorescence. This is retina new vessels elsewhere in the retina. This is retina, not choroidal. This is retina new vessels. This is a proliferative stage of diabetic retinopathy. Because if new vessel comes anywhere in the diabetic patient, it is a proliferative stage of diabetic retinopathy. So filling defect example is hypoxic retina. And see, the retina new vessels are in front of the retina. They are above the retina, in front of the retina. They are abnormal. They can leak the dye, they can leak the blood also. So if they leak the blood, you see this and tell me this is angio or auto. See the dye, right angiography. This is the blood which is in front of the retina. Because retina new vessels are above the retina, they are leaking the dye into the vitreous cavity. This is vitreous hemorrhage, pre-retinal hemorrhage. You cannot see behind anything. You cannot see anything behind the retina. So this is a masking of fluorescence. Any blood, any pre-retinal hemorrhage or any hemorrhage per se will be masking the dye, causing hypofluorescence. You cannot see anything behind the retina, na? That's why it is in front of the retina. Pre-retinal hemorrhage, vitreous hemorrhage, even intraretinal hemorrhages are hypofluorescence. Because when the dye comes into the any hemorrhage, it loses a fluorescence property. And if there is no fluorescence property, no emitting of higher wavelength. So any hemorrhage will be hypofluorescence. Here it is masking the choroidal and retina structure. That's an example of hypofluorescence. Filling defect, ischemic retina, any hemorrhage will mask the fluorescence, that is pre-retinal hemorrhage. So this I gave you example of hyperfluorescence and hypofluorescence. This is I told you proliferative diabetic retinopathy stage. Now let us see one more example. Let us see, can you tell me these two are auto or angio? Please everyone, auto or angio? Both are autofluorescence. Autofluorescence can come one as an exam in the PG exam, one as a normal to identify, or these two investigations. There are these two conditions. And if you know some retina pathology, this is Stargardt's and Best. These are the dystrophies of the last layer of the retina, RP layer dystrophies. And if you have attended my class, how to differentiate Stargardt's and Best, I hope you know something like this. Very carefully. There's a young boy and a young girl. So many daggers are there. Valentine Day was there yesterday. So many daggers are there in the young boy, but still he is smiling. I'll zoom it. Smiling is still okay. He's saying sorry as well. And girl has a small cut and saying she's in a lot of pain. Means, who has more signs? Boy or girl? Boy has more signs, zero symptoms, negative symptoms. Girl has less signs, more symptoms. Where do you see all these? Yeah, one in Valentine Day and one in Stargardt's and Best. Stargardt and Best, if you see, both are having lipofuscin deposit. Now, lipofuscin also has a property of autofluorescence. But in Stargardt, this fundus picture won't be as very, this small yellow things are at the RP layer everywhere in the retina. In Best, only in the central retina. Like a egg yolk, scrambled egg appearance. So, here in this Stargardt, young patient comes, the patient says, I can't see anything, symptoms are more. Doctor says, I also can't see anything. It's very difficult to diagnose. Both says, I can't see anything. Means doctor says, I can't see any signs. Here, the vision is normal, good vision, but signs are more. Okay. And this lipofuscin also has a property of autofluorescence. That is why if you see over here, this is autofluorescence in the central retina, in the RP, in Best, scattered all over the retina. The scattered word is known as flex. The scattered word is known as flex in Stargardt's. So this picture of autofluorescence can also be asked. But now, where is lipofuscin deposited in RP layer? So one more picture can be asked, and this is a very important theoretical question. Can you tell me this is auto or angio? In Stargardt's, autofluorescence. Not normal, abnormal. Some dark is there. Everything is dark. Why? Because the lipofuscin is deposited in the RP layer and covering the entire RP layer, that choroid vessels are not seen. MCQ. Dark choroid is seen on angiography in Stargardt's. Dark choroid, the entire choroid is not seen because RP is covered, the entire retina is covered by lipofuscin. That is why dark choroid is seen on angiography. And yes, autofluorescence is helpful in Stargardt's and BEST. Alright, that is the basics from me. Let us now try to interpret. Now, if you have understood this, if you know the retina pathologies, let us see who can answer this question. I answered this for you. Let us, last 5 minutes. Angio, auto. Answer should be, sir, right angiography. Abnormal. Hyper, hypo. So small dot, hyperfluorescence. So answer should be, sir, right retinal fluorescein angiography showing small hyperfluorescence dot in a diabetic patient. I told you this is the first stage. This is microaneurysms. Who can tell me example of what? Leaking, staining, what? Leaking the dye. That is seen in a very mild, non-proliferative diabetic retinopathy. First stage of diabetic retinopathy. Your answer should be this. Good answer. Very good. Second question for today. Let us see. Again hint. Diabetic patient. Uncontrolled diabetes mellitus patient. Let us mark. Sir, right, left. Right. Angio, auto. So right fluorescein angiography showing some dark areas. So dark areas are hypofluorescence. In uncontrolled diabetes mellitus, this is hypoxic retina, example of filling defect. Releasing VEGF. VEGF causes new vessels. This is hyperfluorescence leaking new vessels elsewhere. Not on the optic disc, elsewhere in the retina. This is a proliferative diabetic retinopathy stage. It has what? Hypoxic fluorescence, hypofluorescence also, and new vessels hyperfluorescence also. All these are hyperfluorescence. This one. Who answered? Everyone answered correctly. Very good. Second question for you today. Let me ask you one difficult one. Achha, at least you can tell me auto or angio. Autofluorescence. No dye. But I told you, only two deposits at your level are having property of autofluorescence. One is drusense, one is lipofuscin. Lipofuscin I told you, Stargardt and BEST. So this cannot be Stargardt BEST. So this is what? This is optic disc drusense. Not asked in PG exam till now, but at least you can tell me this is auto or angio. That is more than enough. This is optic disc drusense, which drusense can be seen in macular degeneration. These can be some normal or abnormal findings in some syndromes. But on autofluorescence, drusense have a property of fluorescence. Very good answer, Subhash. Excellent. Monisha, good. But you can answer this question. I told you, I asked something when I showed you, when I was mentioning something, that in occult choroidal pathologies, ICG better or angiography? Occult means hidden choroidal pathologies, a very old NEET exam question. Very difficult. ICG is better for occult, hidden choroidal pathologies. So at least you can tell me this is auto or angio. Right? Angiography. And all these are what? Dark areas means hypo, hyper, hypo. Hypo can be due to filling defect or due to masking. So this is what? This is also ARMD. Wet ARMD has choroidal new vessels. But new vessels are leaking the dye. That will be hyper. But if they leak the dye, they can leak the blood also. So this is blood. My question is, last question, can you tell me this hemorrhage is pre-retinal or behind the retina? This is my question. This is blood hemorrhage, but it is pre-retinal or subretinal. Subretinal means behind. This is masking. Yes, this is behind the retina. How do you say? So because we are seeing the retina blood vessels. So this hemorrhage should be behind. This is the hemorrhage due to choroidal new vessels, which is behind the retina. Yes, they might be choroidal new vessels, but now the blood has also started leaking. If the blood is leaking, you cannot view anything. And when the dye comes into the blood, it loses the fluorescence property. So this is behind the retina, known as subretinal hemorrhage, because you can see the retina vessels. So this is also example of what? Filling defect or masking. Masking of fluorescence. Very good answer, everyone. I think we are on dot. It's 8 o'clock. That's my time. I hope you were able to understand the retinal angiography and the structural optical coherence tomography. This is, I think, live on DAMS Tele. You can subscribe DAMS Tele for, you have videos, you have going the sessions like this. And thank you very much from my side. Any questions? You can ask me anything personally also, or you can ask me. You can have comments here. I will see later and I will answer. All right. Thank you very much from my side. Best wishes.